Good afternoon, everyone. Welcome to this the last session of the afternoon. I am Odile Rosy from Toulouse in France. And thank you to be there instead to be near the sea at this time. And
hi, I'm Erin Demacos from the U.S. Welcome to the last session. Thank you for coming, and we're going to stay on time and have questions and answers at the end of the presentation. Our next speaker is Dr. Fabio Efficace from Italy on quality of life.
Thank you for the right pronunciation, and good afternoon, everyone. Let's move on. That's my disclosure. Well, in this presentation, I will spend the first few slides explaining you the uniqueness of quality of life data. So I will bring some arguments to say that this kind of information can only be get by asking our patient and cannot be get in other ways. And the second part of the presentation is about the role of quality of life in clinical trials. Well, first of all, let me make some clarification about the terminology, because sometimes we read about quality of life, sometimes we read about patient-reported outcomes. Patient-reported outcomes is actually an umbrella term which also includes quality of life, because in some instances I might be interested just in assessing fatigue or pain or whatever, so just a specific aspect. In some other context, I might be interested in assessing quality of life, which is a wider construct. So in any case, as long as this type of data is reported by patient, we can talk about patient-reported outcomes. Well, that said, I'm going to briefly comment this study. This was published in Lancet Oncology in 2015. This was an hypothesis-driven study. So the idea was to actually to look at whether baseline fatigue, as reported by patient themselves, provided prognostic information beyond the IPSS, the IPSS revised version, and the WHO PSS classification. Here I'm just showing you this slide. This is the overall survival curve of patients with low fatigue at baseline. So at the time of diagnosis, they had a median survival of 19 months. And this is the survival curve of patients with high fatigue, which had a survival of 14 months. I'm not going to show you the full data, but we then tested whether fatigue provided additional independent prognostic information beyond the 3 indexes, and this was the case. And let me also say, sorry about that this was was an international study just focused on higher risk disease. So we're talking about higher risk disease. Let's move on. Well, based on this finding that fatigue provided independent prognostic information for overall survival in higher risk patients, the next step was actually to investigate whether we could integrate this parameter, that is fatigue, into clinically relevant information, whether it could be integrated into the IPSS classification. So the next step was devise what was named the fatigue IPSS classification, which basically included the information of fatigue along with the cytogenetic, blast, and cytopenia. And this index was actually independently validated in 2 cohorts. So the first one was in an independent cohort from the Dana-Farber Cancer Institute. And the second, more recent independent external validation was from the Canadian MDS registry. And this is important when you come up with a new prognostic index, because you want that this index is externally validated. So in essence, the fatigue IPSS index is a patient-centered index, and I would say a pragmatic index in the sense that does not require any extra laboratory exam or any other clinical evaluation. Basically, it only implies the assessment of the fatigue using the QLQC30 scale, so just 3 items. So based on 3 items, we are able to identify a patient with low or high fatigue. Let's move on, and I'm going to show you that this line of research, basically the importance of the quality of life data or patient-reported outcome data when looking at prognosis, it's a very important aspect. So, and before doing this, these are the survival curve stemming from the MDS Canadian Registry. You see that we can identify 3 groups of patients rather than the 2 as identified with the IPSS classification, rather than identifying intermediate to and high risk. By using the fatigue IPSS, we were able to identify 3 groups of patients. About the importance of this line of research, these are not standalone findings. Actually, I'm going to show you the literature on this topic in MDS. It's broader than this, and I'm going to show you these 2 more recent articles, and there is more, but these were recently published. This in 2013, and I'm going to show you, sorry about this. This study published in American Journal of Hematology a few weeks ago. In this study, the authors mainly look at the quality of life trajectory in MDS risk patients who undergone transplantation. And they were also looking among different analyses and the prognostic value of pre-transplant quality of life for survival outcomes. And this is what the authors concluded, actually. The baseline PRO score were actually very important predictor of survival in this group. And they also concluded, actually, that about the importance of adding pre-transplantation quality of life. And this one is to be considered among the eligibility criteria for transplantation. So the key message from this line of research is that this type of information provide clinically relevant information that goes beyond what you are typically measuring in clinical practice with these patients. And to add on this argument, I mean, what has been observed in patients with MDS is actually fully corroborated with more than 20 years of research in patients with solid tumors. Because this type of evidence, I mean, the fact that quality of life data or patient-reported outcome data do provide prognostic information for survival, has been observed across different solid cancer, other type of hematological malignancy, has been observed by using different type of quality of life measures. So this is just to say that this is a pretty consistent finding in the cancer literature in general. But we have started to see this type of evidence in MDS over the last few years. Now, let me move on with the second part of the presentation, where I would like to give an idea of the use of quality of life in clinical trials, mainly, I would say, in comparative randomized phase 3 trials. I could have shown you the use of quality of life data in different settings. For example, quality of life data can be used in clinical practice for different purposes. But I decided to give you this very broad overview of these 2 major topics. These are 2 important documents recently published by the MDS Registry, this fantastic group of European researchers, basically pointing out the important role of patient-reported outcomes in clinical research. But moving from this, you might probably know this article recently published in Blood. Actually, I'm not going to spend time in all the details, but one of the key recommendations is the inclusion of PRO in clinical trials in higher risk MDS patients. And let's move on now. We go deep about the challenge of assessing quality of life in clinical trials. Now, these are the quality of life measures that I've often used in MDS research. So we have seen studies using generic measure. When I say generic measure, for example, the EQ5D, and you probably know the EQ5D, this is a general measure. It's not even specific for cancer patients. And then we have used many of the trial and the study in MDS have used the QLQC30. We have evidence that the QLQC30 has been the most frequently used measure in clinical trial in MDS. And then we got these 2 MDS-specific measures that have been specifically developed for MDS patients. The QUANTS is actually was recently validated also in a European setting, was part of the, was an EU MDS RIPE project, which included European and Israeli patients. So the QUANTS was originally validated in the US, but it also was recently published in Cancer Medicine about the European validation of this questionnaire. But I would say what we are facing in MDS is a rapidly evolving treatment landscape. So if I had to identify two key words in MDS arena, I would say pragmatism and flexibility. Therefore, I would like to mention about the use of, I don't know, many of you knows the use of item library. So when we are assessing QualLife, when we're assessing PRO, we can also rely on this library. Each of these libraries contain hundreds of items, validated items about fatigues, other symptoms, or QualLife functional aspect. And I'm going to show you a concrete example of how this library can be used. Because, for example, they can be used to complement some aspect which are not present in this measure. And this might be the case when we have a novel drug. Sometimes we don't know what are the side effects. And it's possible that the side effects we are going to face in this trial are actually not included in this questionnaire. So we want to complement what you're measuring. Or in some instances, we actually want to replace the use of this study questionnaire with this one. So I briefly mentioned about the PRO CTCAE item library. This was developed by the US NCI, within the US NCI framework. And the way it works about this library is that you have a list of items, in this case, symptomatic toxicity. These are something like 80 different symptomatic toxicity, which are to be evaluated by patients themselves. And the way it works is that you select from this library what you actually feel are important for the specific research setting. For example, you have a phase 2 trial, and you don't know what might be the specific side effects as experienced by patient themselves, and these kind of side effects are not included in standard questionnaire. Well, you want to be flexible, and you might want to select, this is just an example, just the item that you like and to administer to your patient. Also because you might want to keep the patient-reported outcome assessment short, brief, and pragmatic. So, for example, in phase 2 trial, you might just want to use a brief selection of specific symptomatic toxicity. And, or for example, when you have a trial investigating a novel drugs, well, you might want to use this type of approach. Just to say something about the use of PRO in phase 2 trial, it is critical because it can inform the design of a phase 3 trial. So I'm not going to spend time in saying how it's important to the inclusion of some selected PRO items also in phase 2 trials, but I will invite you to read, for example, this paper in Nature Medicine, talking about the role of PRO in early phase clinical trial. But in the essence, it's about better designing phase 3 randomized trial. Now, having said that, we have discussed about the value of QualLife in clinical trial. But the key issue here is about methodology, because we know very well, and this is something that we have learned from many years of research in oncology, that methodologically weak PRO study unlikely will provide clinically meaningful information that we can use in clinical practice. So running a study with high methodological standards is critical. That's a key aspect that has been highlighted by regulators, by the scientific community. So we are to be fully aware of the key issue of the importance of methodology, because the stakes are high. For example, can you imagine that you have a novel drugs or a novel therapeutic approach which can potentially provide some QualLife benefit from our patient experimental arm, but the trial is designed in a way, is analyzed in a way, is reported in a way in scientific publication, which will not allow this benefit to emerge. And this is definitely a risk that we don't want to take. So the fact that, for example, a trial doesn't show a difference between treatment arms in terms of QualLife, it might be plausible, because it can be the case, absolutely. But it can also be the other way around, because the trial is not designed let's say, and according to a number of methodological issues. So we're not going to go into details about the methodological issues, but I just want to show you very briefly what is emerging from, this is one of the latest documents published by the FDA about how quality of life and patient-reported outcome assessment should be conducted in clinical trials. This was published just a few weeks ago. And I'm going to mention about the challenge of missing data. When you run a trial with quality of life, having missing data, it's normal. The issue is that to what extent this missing data can actually reduce in the power of the analysis. And the other issue is whether you analyze the missing data in a way that allows you to consider whether this is an informative dropout pattern between treatment arms, simply because patient cannot provide quality of life questionnaire because the drug that you're testing is more toxic. So I'm going to move very quickly. I'm going to give you an example of one of the challenges and the way you should actually report and present the data. And I'm going to show you this. You probably know this trial. The primary endpoint was actually RBC transfusion, the rate of RBC transfusion independence in low-risk non-LQ5. And you probably know this publication in JCO, but the authors actually published a standalone quality of life publication, and it should be done in this case because the amount of information you need to provide the scientific community, it's huge. So this is the way, actually, you can plot the clinical significance of the outcomes. These were the 5 pre-selected scale in the protocol selected as secondary outcomes. And this is the proportion of the patient with the lenalidomide versus placebo in each scale having improved, clinically significant improve in fatigue as compared to the stable and worse. So this is a way of presenting the data, and this is a way of showing how clinical significance is important, because when you are dealing with patient-reported outcomes, it's not just a matter of statistical significance, but it's also a matter of clinical significance. But we're not going to go into details of this. I'm about to conclude, and I'm just going to show you this slide, just to say that in the international literature, we have some guidance that we can use in general. Of course, we should be more specific in MDS because we have unique challenges in MDS, and it also depends whether we are dealing with low-risk MDS or high-risk MDS. But in any case, this provides a general framework or how to write a protocol which includes quality of life data and how to report this data in a meaningful way and in a transparent way in scientific publication. So I'm going to jump to the conclusion, just say that quality of life data provide unique information that cannot be picked up by looking at any other type of information. And the inclusion of quality of life data or patient-reported outcomes in general in clinical trial is crucial to better understand overall treatment effectiveness and helping us to make more informed treatment decisions, because it's the only data that can actually reflect the real burden of the therapy from the patient standpoint. And of course, the final point is about methodology. I mean, we have to be mindful that methodology is crucial when we design a clinical trial with a quality of life endpoint. I guess my time has run out, so thank you so much for your attention.
Thank you. So the next speaker is Julien Mancini from France, and he will talk about MDS patient information and health literacy.
So I would like to thank the organizer for giving me the opportunity to talk about health literacy today. So I just work here in Marseille in the public health research lab and on this field. So there are multiple definitions and conceptualization of health literacy that could be quite complicated, but if we look really at the core of this kind of modelization proposed by Sorensen, we will have a long definition, but trying to incorporate all the aspects. Because, of course, health literacy is linked to literacy, and it encompasses people's knowledge, motivation, and competencies. So it's not only about knowledge and competencies, but also include the motivation of people. It will be needed to access, understand, appraise, and apply health information. So again, it's not only about access and understanding information, but really something more broad in order to make judgments and take decisions in everyday life concerning healthcare. So that's the point today, but also more globally, disease prevention and health promotion to maintain or improve quality of life during the life course. So the important things to understand is during long time we only work on patient understanding and what was called functional health literacy. Now the scope is more broad. Another nice way to understand health literacy is to really show this figure with the idea that it's really the product of the individual capacity and the related demands and complexities of the healthcare system. And the context is not really favorable with the aging population. Abilities are not better and better, and there is really an always increasing complexity of the healthcare system with more medication, more tests, more safe care requirement, etc. And the new added complexity is now the digitalization of healthcare. We talk about that a bit later. Last slide about definition, about the multiple aspects of health literacy, a bit like for quality of life, you have generic quality of life and more specific measure. It's the same for health literacy. At the beginning, it was really only general health literacy or only even functional health literacy, but now you have several scales trying to capture digital health literacy, for example, or the capacity to navigate in the healthcare system, etc. And for the dimension, just to mention, because I talk a lot about functional health literacy, because a previous model proposed by NutBeam really insists on separate competencies, and the functional one to really access and understand the information, the communicative one to interact with the system, and the critical aspect to be able to criticize and then to use the information on your daily life. And so to insist on knowledge is not power, and we know that providing, because we talk about patient information today, but providing right information is not enough. You then need to really empower patients if you want them to move on and not only provide information. So there is a growing interest for health literacy, particularly in France. We were late to be interested in this topic. In the US, it started long time before. But why does it matter? Because it's really a strong predictor of persons' health, and even a survey has shown that for elderly patients, it could predict mortality, survival after adjustment for all the usual socio-economic factors that we use in public health. And if we look, for example, at the results of meta-analysis with a lot of studies, people with limited functional literacy, because most of the studies only use this kind of measure, are more likely to have chronic condition they do not manage effectively, have less knowledge, of course, of their condition, but also are more often admitted to the hospital or emergency room for preventable reasons with higher healthcare costs. That's why there is an interest also of politics about trying to move in this context. And globally, they are more likely to report their health condition as poor. So to illustrate this, we can look at the last result of the European Health Literacy Survey that show really a very strong association between the health literacy level and the perceived health of the participants. Let's try to go to the field of MDS. So clearly the situation is not really favorable, because we've got people that are generally quite rather old, so with limited skill. And we also got a stressful disclosure of a life-threatening disease. And it's really important, because you can have rather good skill every day, but when you face this kind of diagnosis, maybe emotionally you won't function the same thing, and so that will limit your abilities to process the information, and so your skills are more limited than usual. And you know that very well, and very compared to me much more, that there is really an high complexity of myelodysplastic syndrome, and several publications have shown the difficulties of patients to really understand myelodysplastic syndrome, their prognosis, their treatment, and their risk of evolution to AML. Despite the situation, there are really a few specific investigations. If you look, for example, on PubMed for ELF literacy and myelodysplastic syndrome, you won't find a lot of articles. But in a previous French-Australian survey, we have shown that inadequate functional ELF literacy was rather frequent and was associated with negative outcome, with more psychological distress in this case. So that brings us to think of what should be done and who should we target. And so who is at risk for low ELF literacy? We already said that older adults are at risk, in particular if they've got hearing, reading difficulties or cognitive difficulties. And globally, there is a social gradient with people with less education and with lower outcome that generally show a lower ELF literacy level. And of course, as it is linked to literacy, and non-native speaker will have usually lower level of ELF literacy. However, it's rather difficult to predict, and a colleague, for example, Professor Laurent Rigal in Paris, have shown that physicians were not really able to predict the level of ELF literacy of their patients. And usually, we should consider that everyone is at risk and take universal precaution. It's important because it's difficult to really predict who's got a lower level of literacy, and also it's not a problem because literate patients are not insulted by low literacy materials, and everyone like clear and simple instruction when it's about their health. So again, the HLS-19 survey to highlight that difficulties are really frequent. And if you look at this one, the last bar, you will show that inadequate and problematic ELF literacy are really frequent, and only 15% here have got an excellent level of ELF literacy in a European survey that won't capture the people with the most difficulty, and because it's only respondents to a large survey with lots of questions. So this one is really adapted from a teaching from Goldman to try to feel what functional ELF literacy feel like if you're not able to understand complex terms or long sentences, you will have problem to read this kind of text and to do what to do next to improve your health or maintain your quality of life. And indeed, it's just a simple report of results, but this actual text is rather difficult. There are several ways to try to measure that. There's a well-known, even if it's criticized, scale that it's the Flesch Kincaid grade level that will tell you the difficulty of a text, and in this case, the text is difficult, and it's above the average level of people because there are medical jargon, long words, long sentences, passive voice, etc. And so what you need to know is that you need, when you write this kind of text, try to reach grade 8 or even less if feasible, but sometimes it's difficult with medical words. And recently it was we get some help to achieve that because colleagues in the Sydney University have proposed the ELF literacy editor that will take this kind of text and underline for you the difficult words, the long sentences, the passive voice, if any, etc. So in the ideal setting, if you write something, you should try to co-design, for example, a pamphlet with low literate patients, and always implicate the consumer with difficulty to understand to be sure that they can understand the text you write. If you don't have enough time or resources, for example, for a simple letter like that, I hope that in the future, artificial intelligence will help. And for example, you can ask directly ChatGPT to give you a simplified version that improves the flesh Kincaid grade level and decreasing it. And you've got a response that is not so bad and that's really easy to read around the 5th grade. You can also try to use this for non-native speaker. I've tried to ask to translate then the simplified version in French. It's not perfect, but there are improvements every day in this field, so perhaps in the future it will be quite easy to have something complex and to say, okay, can you simplify that for a patient that have difficulty understanding? Can you translate in multiple language? And I hope that in the future it will be easily feasible. So globally, what kind of overaction you can try to do if you want to improve the situation? Of course, you can try to improve skills and ability, and health education is really important for that, but it's really difficult to achieve in practice, and most of the work that is done in the field of health literacy was about compensating the situation. And for example, in this kind, you can train patients through therapeutic education or healthcare provider with communication, teaching to help them adapt their communication to low literate patients. And recently, there's a big move to say, okay, we should also try to act the other way and try to decrease the complexity of the system. And so there is a new field of research trying to really understand what could be a health literate organization and what could be done at the system level to ensure that all documents produced, all navigation can be done easily for everyone. So for the clinician, just a reminder of the usual way to improve information if you face a patient with low literacy. It's, of course, to use plain language, to try to limit the number of information you convey and to tailor the information to the patient needs rather than giving all the possible information, to repeat the important instruction and to use teach-back methods to ensure that patient understood correctly the most important point, and, of course, to encourage patient question and participation to be sure that it's not only about knowledge but really involving the patient and reaching patient-centered care. Another good way is that people process the information differently, so it's good to provide also additional information, for example, written information, graphical information, linked to online reliable sources that could be really helpful in this context. And you've got a nice resource, so it's only in English and Spanish, but there are also initiatives in French. But this one was important because the website is really complete with videos, etc. And the feedback recently published is really interesting because, of course, people learn something. It's here, but what's more important for me, it's what is in green, is that people don't say only they learn something with this kind of tool, but say that really it will change their practice because they will use this information, they will discuss with their physician, etc., etc. So that's really a nice initiative you got here. So in conclusion, I would say that health literacy is really an important problem, but it's also a leverage to reduce social inequality, and that's why it's really studied, because compared to other socio-economic determinants, here we really think that we can change things. And if we talk about socioeconomic inequities, and you know that MDS patients, such as other patients, face this kind of problem with poor survival among elderly patients with lower education or living in disadvantaged neighborhoods. MDS are really not well studied regarding health literacy, but more actions are certainly needed given the context, and you can have really field works and important local initiatives that could be useful for your patients. And digitalization of healthcare and artificial intelligence perhaps will help in the future, as I tried to show with ChatGPT, for example. But we really need also to pay attention to the digital divide, and that people, and older people in particular, do not all have access to digital resources, and digital health literacy is something that we need to develop in the future. Thanks a lot for your attention.
Thank you. It's a pleasure to introduce the next speaker, Jacqueline Dubow from France, because she represents the patient's voice at this meeting. She will talk about findings from the MDS Global Survey 2022.
Hi, thank you for having us here. I would like to thank the scientific committee for putting us in the agenda, because I think it's quite important to have the raw voice of the patient. So I'm going to present a survey that we did at the MDS Foundation, at the MDS Alliance. And I'm going to explain what is no disclosure. Okay, the MDS Alliance, it's a group, it's a network of about 40 associations within 30 countries. And those associations are either specifically MDS, or MDS is incorporated within a larger group of disease. So what are we looking for? We are just looking for the optimal care for all MDS patients. That's the goal we have. And the way we are working, we have a steering committee of 10 people. You can see they are spread all over the US, Canada, and Europe. And we, as members of the steering committees, I think we are extremely knowledgeable on the MDS ecosystem on the patient side. So this study was done by the Scientific Education Support in the UK. It was funded by BMS, and I must say that BMS did not intervene during the study. We are completely free. And the steering committee was leading the survey. I want to precise that Sandra Curtin, who is unfortunately not with us, was the PI of that study. So the aim of the study was to better understand and raise awareness of issues experienced by individuals living with MDS. I mean, the raw voice of the patient. And we want to use this understanding to make evidence-based decision on how to improve the quality of life and the access of care. I would like to mention that very often the work of patient associations, patient advocates, is not recognized because we don't publish in the literature. I mean, if you do a PubMed research, you are not going to find those studies. And some of them are excellent. I mean, there is a need to understand that the patients' advocates are getting more and more professionals and are bringing more and more evidence-based information or data. So the way the survey design was done, the data were collected between November 21 and April 22. We use, of course, all our members to spread the information. Patients, before going through the survey, had to fill out a consent form. If the consent form was not filled, there was no access to the survey. And the survey was translated in 10 languages, because often those surveys are done in English, so it reduces drastically the access. So first, we did a questionnaire. We created a survey plan. We document the research questions. We developed the survey. We pre-test the survey. And then the survey was translated in 10 languages. And the translation were done by highly professional translator. So we had a set of questions. Here, we wanted to be too large. And our question wanted to cover the entire spectrum. So we ended with a final survey of 8 sections. And why I'm insisting on that, the survey was about 45 minutes long, which was quite difficult for some patients, but I'll come back to that later. So at the beginning, the usual demographics, then the disease history, the overall health status of the respondent, the mental health and well-being of the respondents, quality of life. Quality of life was assessed through the QALMs. We also have questions about access to care and COVID effects, and then improving quality of life and access to care. So the way we spread the word, we use all our associations, members, to do their work, and they did it pretty well. They received details on the survey. It was in their own language. There was a draft email that they could send to their network, and they were also receiving social media graphics that they could localize, and depending on the local context. And everything was in their own language. I'm insisting on that. And then the MDS global survey was looked at by the people from the steering committee, and we also use our own network to spread the word more. There was a fairly big social media campaign, and it was launched through the MDS Alliance website, Facebook, Instagram, LinkedIn, and Twitter. So we were quite vocal. And a special page was created on our website, so people could go on that page and they could choose the language in which they would respond. Survey completion, we got a 65% response. That was unexpected, good. And we got over 900 people responding, but a little bit over 500 people completed the survey. It means, it's important because responding to a 45-minute survey by 500 people all over the world is pretty good. So here, if you can read, you have the completion rate per country. Of course, Europe and North America have the most respondents. The continent that has a 100% completion is Africa, but there was only one respondent. So nice way to use the data. So demographics. Most of the people were in urban area. Most of them, over 60%, were with a spouse and a partner. 18% were living alone. 12% within an immediate family, only 0.6% in a residential facility. And we had a little bit more female than male responding. And looking at the education level, most of the people were having a fairly high level of education. So it means for us, patient association, that we are good at reaching people with a good level of education, but we are not reaching the people who are the most in need. In terms of health insurance, it was a surprising number. 85% have health insurance and only close to 15% did not have. But knowing that most of the respondents were coming from the US, this was an interesting response, but this might be linked to the high level of education of the respondent. So disease history. Only 3 months, that was the median time between symptom and MDS diagnosis. It's fairly short. 62%, almost 63% of the patients said that fatigue was the triggering factor. Testing, prior diagnostic. Blood test was done for almost everybody, 96%. Bone marrow test, close to 90%. Chromosomic test, 36%. Flow cytometry, 17%. Molecular test, 9.1%. So here we see a big hole. Only 9.1% are receiving molecular tests. And this is, again, we are dealing with people with fairly high income level, fairly high level of education, and most of them are in developed countries. So this is a fairly low number. So risk level and subtype. Close to 54% of the participants did not know their IPSS risk at the time of the diagnostic. And almost 30% of them did not know their subtype. How did they learn? 40% of them learned because they were told. Close to 6% did their own research, and the rest did not know. So here there are still some efforts to be made. Treatments. 20% don't have any treatment. 52% are receiving blood transfusion. 45% are on EPO. And close to 15% have received a bone marrow transplant. So most of the respondents were in the low risk. Here, another disturbing number for a patient. 74% have never heard or have never been asked to participate in a clinical trial. So here we are back to the nice bubbles that are created within clinical trials and the frustration of the patient because they cannot go to a clinical trial and they are not even informed. So here we ask the participants to mention 2 things that would improve their quality of life. And it's a wish list, I agree. So I apologize because the first 2 responses, the most important, are not shown on my slides. 16% of the patients are requesting access to quality information. And here it's important because they are not asking for information, they're asking for quality information. So they know how to make the difference between weird information and good information. So in terms of health literacy, we have some, even among elderly patients. The second the second wish was 15% wants to have a better emotional support. It's clear that this support, despite that many centers offer psychological support, it's still missing. And this might be linked to the complexity and the heterogeneity of the MDS. We have 10%, close to 11%, they said, well, we don't need nothing. That's interesting. Here, that's a message for the physicians. 9% of the respondents would like to have more knowledgeable, more caring and forthcoming support from their physicians. 8% would like to have less fatigue and better physical well-being. 8.5% wants to have more effective treatment options. And here again, very quickly, MDS patients, despite being old people, realize that the options are not very important. I mean, not so many options in terms of treatment. So, same thing, more accessible specialist treatments for 7%. Only 5%, 5.7% are asking for a cure. And you would think that it might be the number one wish. No. Better transfusion or less transfusion, 5%. Insurance-related, almost 5%, but that's mainly for people in the US. Financial support advice, 3.4. I don't know, 3 points. And COVID, it's only 2.8%. It was not really in the mind of the respondent. Exercise. Patients are very often, and I think almost, are told that if we try to exercise by walking or doing something simple, it's going to help you. But it's not exactly on the radar of the patients because only 2.8% are asking for more information about how to exercise. 2.4% didn't want to share. More access to medication, 2.2. Public awareness of the disease, 2.2%. And it's important because when you have a rare disease, you cannot explain what it is because it's a rare disease. And even among some GPs, the knowledge of MDS is not great. So it makes the situation of MDS patients more complicated. Support from family, friends, only 2%, means that the family support is probably pretty good. Better over health, only 2%. Holistic care, 2%. More research, 1.8. Blood counts. People are tired of giving their blood. Pain management, not too many people. And I'm moving quickly because I don't have so much time. Stem cell transplant, only 1.2% have put on their wish list stem cell transplant. And that's a baffling result because when you put MDS patients together in a room in face of specialists, like it was last Wednesday, half of the questions are about stem cell transplant. So here, I don't know what happened, but it's a weird result. And only 1.2% are wishing for MDS Center of Excellence. And those people may live in countries where there is no Center of Excellence.
Jacqueline, sorry, you have to conclude, please.
Okay, quite important, COVID effect on the patient, no. almost 80% did say no effect on us. So in conclusion, patients are tired of being tired. Nothing new here. Improving communication between patient and healthcare providers. Sometimes patients had the feeling that when they were asking help from their doctors, it was not always forthcoming. At diagnostic, they want more understandable and credible information. And here there is clearly an information gap. This information gap becomes narrow when the patients are going within the disease. More information on clinical trials, and that's where patient associations can help. Access to medication is an issue because not all medications are available in all countries, even in countries that it was mentioned, countries with a pretty wealthy healthcare system don't give authorization to all medications, and less frequent blood transfusion. So thank you very much for your attention.
Thank you.
Our last speaker is Dr. Amir Zaiden from Yale Cancer Center in the United States on patients' perspectives on oral decitabine and cetirizine for the treatment of MDS.
Thank you so much for the organizers for accepting this abstract for presentation and this visit to this amazing city. And like the last speaker, I think it's very important to get the patient voice, important presence in these meetings, and I think this discussion about patient perspectives is important. So these are my disclosures. Relevant to this is that I consulted for Taiho. So oral decitabine, cedazoridine, was approved in the US in the year 2020. We know that hypomethylating agents continue to be the standard of care in the management of MDS, in particular high-risk disease. However, we actually and others have done a lot of studies that showed that many patients who would be eligible for hypomethylating agents are not getting them. More than 50% of patients do not get them. And the reason for that, as you heard from the last speaker, is that most of the patients are older. They have limited social support. They don't have anybody to drive them back and forth for 7 days of azacitidine every month. And even among those who get started on treatment, many of them do not continue beyond 2 to 3 cycles. We know that in order to get response out of HMAs, you generally need to have at least 4 to 6 cycles. And this lack of persistence has been shown to correlate with worse outcomes. So finding alternatives to injectable hypomethylating agents have been, I think, something that was important. And the approval of oral decitabine hopefully has opened the door for more compliance and more persistence of HMA treatment, which continues to be important for demonstrating the best efficacy out of them. However, also, hypomethylating agents, of course, are given by injection. They are associated with pain and anxiety, leading to come frequently to the clinic. And most patients in previous surveys have indicated they prefer an oral option if possible. And we conducted this survey, basically, to understand the patient perspectives on the use of oral decitabine. So this is a cohort of patients in the US who have received oral decitabine. And we wanted to understand their satisfaction of the treatment, the impact on their quality of life and daily activities, as well as their experience with oral decitabine compared to their previous experience with the injectable hypomethylating agents. So this was an online survey, similar to the previous speaker, how she described. The drug was approved in the US in August 2020. The survey was done between 21 and 22. And you can see here the completion was mostly towards the end of 2022. This was a 25-item questionnaire, and it took around 15 minutes. In general, in surveys, you prefer not to go too long because people tend to give up on them if they take a very long time. And you try to get questions that have specific answers. So most of the questions had fixed responses, and 2 questions has free text, as I'm going to show you in a minute. So the patients who responded to the survey were a total of 150 patients. You can see that most of them were older than 60, and most of them were male, which is consistent with the demographics of MDS in general. You can see that most patients were receiving the oral decitabine at the time when they responded. They have not discontinued at that point. Only 18% had discontinued. And most of them, around half of them, have taken the drug for more than 6 months, and 60% have seen injectable hypomethylating agents. So around 40% have started on the oral decitabine from the get-go, while the other 60% have received injectable formulation of hypomethylating agents before they receive decitabine. So those are the results. What you can see here is in these pie charts. In green are the favorable responses. And you can see here the way we graded the responses generally for the convenience and satisfaction with oral treatment. Convenient or extremely convenient, more than 80%. The same thing for the satisfaction with the treatment. When you look at the impact on daily activities, and I think this is important because while azacitidine is given by injection subcutaneously over 15-20 minutes, as you know, in most places the patient will need to drive for an hour or two, has to wait outside the room basically for the injection for another hour, depending on how efficient your center is. So it could take half a day just to get an AZA injection. It's not that quick. So I think this reflected very well in this question, in which most patients have indicated that oral decitabine basically was very favorable in terms of not affecting their regular daily activities, as you can see in the green, or does not interfere with their social activities or with their productivity. And again, probably none of this is surprising, but I think it's important to see it in actual data, as you can see here in this survey. The next domain of questions was looking at their experience compared to prior use of IV and subcutaneous hypomethylating agents. And you can see again in green are the favorable responses. So most patients indicated that there is less interference with their daily life activities, and they were able, the use of oral drug allowed them to cope with the disease in a better way compared to their previous experience with the injectable drugs, and it helped them to maintain independence. Again, it's very important because they don't have to rely on someone driving them back and forth to the clinic to get the infusion, and clearly reduce the number of times they had to go to the physician or to the infusion center. And lastly, we wanted to compare their experience with other treatment compared to the oral decitabine. And you can see here again in green that they have, most patients indicated they had a positive personal benefit from the drug, and that it has improved their quality of life, and they were happy that they have switched. So this is, I think, an evolving area of use in the US, where patients, especially when they are in complete remission, when they are not needing transfusions, so they are just coming to get the injection, I think this is probably a very good opportunity to switch some of the patients who have been already on injectable hypomethylating agents. So the limitations, like any survey, similar to what you have heard from the previous speaker, most of the MDS patients are older. They are not very good at navigating computers, etc. So there could be a bias here for patients who are more educated, who can take these surveys. And also the way the patients were selected, we had local hematologists and oncologists approach their patients. So there could have been a bias in the patient who are responding. And lastly, in general, people who have very positive experience in general in surveys tend to be the ones who respond more to these surveys. So all of these things could have biased the numbers, but I think overall the direction has been consistent with a positive experience. And we did not look at the disease characteristics compared to the last speaker. Like, we did not ask about higher and lower risk disease. We did not look at objective outcomes. It was focused on the patient experience. And lastly, for the patient who had stopped the oral decitabine, we did not ask about the reasons for stopping the treatment. So in conclusion, this is actually, I believe, the first survey to look at patient experience using oral hypomethylating agents for MDS. We have another poster looking at the real-world experience of using oral decitabine. It's outside in the poster hall. And again, I think this is an increasing number of patients in the US who are getting those oral hypomethylating agents. I believe the drug is not approved in Europe, but certainly we are seeing more patients using it. And overall, the data is consistent with the expectation that personal experience reducing the visit number to the clinic, as well as potential to reduce the treatment burden of patients, appear to be the case. And I think, as you heard from Dr. Efficace and other speakers, I think understanding the impact of treatments on patient experience and quality of life is very important. So thank you so much, and I'd like to acknowledge the sponsor and the medical writing team who helped with this, writing the slides. Thank you so much.
I know we're running a little bit over. There's no one following us, so we'd invite the speakers to come up and have this opportunity for the audience to ask any questions.
I would ask a question to Fabio Efficace, or perhaps have his comments. You mentioned that one of the pitfalls in quality of life studies in clinical trials, you mentioned about data interpretation. My impression is that there's another one which is perhaps very important, is the fact that if you take the example of trials in low-risk MDS where you compare transfusions to a new drug, say a drug X, the comparison for quality of life is always made between the treated group by X and the placebo group. That is the transfused group. And my impression, and almost in all cases, the conclusion has been negative, although the drug had significant effect. And my impression is that the comparison should be made by transfused patients and patients who respond to X, because that's the real life. And that is what patients and also health agencies want to know in the end. It's the long-term use of the drug versus the just being transfused. And this is never made, so I think it would be important in future trials. Yeah.
It's absolutely important. It's never, I guess, has never been done, but it's one of the. We have so many things to put in the next research agenda, and what you are saying is something that I would definitely put in the agenda. Absolutely, absolutely. Thank you so much for raising the issue. It's so important.
Well, thank you to the speakers for the great presentation. And I would like to ask a question to Marie-Caroline. Thank you for your talks. My question is very simple. So you mentioned that some patients express fear against artificial intelligence in health. So what's next? What could you propose? And is there something that come to the government or to the institution to say we will protect you?
Thank you for your question. Yes, it's an important question. I think that's the aim of constructing an ethical framework. I think the government is here to put some rules, law in the country, and maybe not to come and secure every wanderings of the patients, because when the patients say that they want to be able to secure to the data, that could be from the government perspective, but there are other questions and expectations of the patients. For example, they want to be able to have an eye of what is happening with AI, what we are doing with the personal data. And this is more something that should be constructed, I think, not by the institutions, but it should be more like what we call soft rules, I think. And we should have a frame, but not a frame that would be something that we built with laws, but just good practices that everyone could use. And for that, we first need to write it, and maybe the agencies, the authority could relay the message, but I think the good practices is something that just comes and that is used by everyone, and we shouldn't just spread the word, and so we need to build that frame and just to broadcast that frame, so the expectations of the patient would be respected, and of course the regulation by the agencies is very important, but it's not enough, and it can be they can't be everywhere, so it's also the society and the other elements of the society that can help bring and broadcast this ethical framework.
Thank you. This is Reinhard Stauder. I have a question to Fabio Efficace. Fabio, you had an excellent presentation, outstanding overview. How do you think that the health authorities will impact the integration of quality of life scoring in clinical studies? Or in other words, for the registration of some drugs now, quality of life or data patient perception is necessary. How do you feel will be the impact of that legal situation of this?
Yeah, regulators have been advocating the use of patient-reported outcomes clinical trial for quite a few years now, and they have published a series of documents. The key issue that I would like to mention is that it's about methodology. I mean, as long as you provide high-quality data, this is something that can be very, very helpful. I mean, one of the top idea that I have in mind is the approval of ruxolitinib for patients with myelofibrosis. It was obtained based on a reduction in pain that was used as a group primary endpoint. So this is the best example I can have. So this is just to say, if it's done properly in terms of design, analysis, and reporting, they can actually provide absolutely meaningful data to support drugs or labeling. But the methodology is crucial. There are so many things. It's not just a matter of selecting the top quality of life measure. It's much more than this. It's selecting the most appropriate endpoint, which are actually able to capture what you want to capture. It's about the missing data, so many things. But this is highly endorsed by regulators.
May I have a second question to Amma Saidan? So this was an excellent presentation to demonstrate the impact of oral hypomethylation agents on the functional activities of the patients. Have you considered to integrate this common toxicity criteria adverse events scale where the patients report their adverse events, because gastrointestinal disturbances may be a concern or a challenge?
Yeah, no, this is a good thought. In this particular survey, we have not asked specifically about adverse events, but I think this is something certainly can be considered in subsequent surveys.
So I had also a question for Amma following your presentation. That there are probably two aspects between the parenteral and oral administration of drug, and also the fact of having to go to the hospital. For example, in this country, in many places, azacitidine is administered at home. EPO is administered at home, and even I just learned that here in Marseille they offer to patients transfusion at home, red blood cell transfusion at home when it's possible. So this is the other aspect, having to go to a hospital. I understand that, it's probably variable for Europe, but in many situations patients can have, in particular, private nurses at home. I understand in the US it's still, you still have to go a lot to the hospital for many, including for HMA injection and perhaps even for EPO administration, or is it changing, or is it? Yeah.
No, you are absolutely right. There is a lot of geographic variations, and there are multiple reasons for it. Like some of it is regulatory, some of it is insurance, some of it is states. But in the U.S., I would say the vast, I personally do not know of any place where you give azacitidine in the U.S. like at home. Even the ESAs, as you were saying, while it's very common in Europe to do them at home, in the U.S. it's mostly given in the physician office, but that's largely related to the insurance nature in the U.S. is that if you do things at home, you could be subject to a significant copay, which many patients cannot afford. So sometimes we have patients, even with the oral decitabine, we have patients, which I think is a kind of a sad situation. We have patients who choose to come to the office 7 days a month just because if they are going to take the oral version, they have to pay a significant copay, which they cannot afford. So a lot of these I think are kind of dependent on the geography. But I'm actually very impressed. I've never also had blood transfusions at home. This is like, I think, very impressive setup that you have here. So maybe, hopefully, we can do some of this in the US.
Go ahead.
Yes, Norbert Vey from Marseille. I was interested by what you said regarding the health literacy and more specifically the digital literacy. And I think that the problem is that the digital tools might be a way to improve the health literacy. So how do we reconcile these two problems? So it's a question for you, Julien, or Dr. Ley.
Of course, digital tools can help, but you need to ensure that they are used by people. So it's not. It can be reconciled easily if the tools are well planned, and there's now there are kind of checklists when you conceive the digital tools to ensure that all the people will understand that, for example, you need this kind of usual menus with the hamburger, simple things, and so there are ways to design tools that are easy to use. So if you add this kind of tools, they will profit to most people. I'm not sure if I respond enough.
Yes, I would like to make a comment about the use of artificial intelligence. That is going to be a very useful tool to better understand the disease we are speaking about during these days. In Europe, we are trying to set up a European Cancer Research Data Hub, and we need to set up this data hub as a federated data hub because of the GDPR regulation in Europe. And this is a major obstacle to share data, even though, according to a survey that we perform across the patients with cancer, there is a wish of the patients to share their data to help improving the understanding of this disease. So this is where we need a strong support and lobbying of patients to help us to simplify the use of GDPR regulation to better share the cancer research data.
As a patient, I totally agree. Patients are absolutely okay for sharing their data. There is no problem. And I would like to say that artificial intelligence is embedded in so many applications that people don't even know that artificial intelligence is being used. So I don't think, from a patient perspective, we need to blow up that issue. And I'm in agreement with you that we should lower those regulations. So I don't know if you...
Yes, maybe I'm a little more mitigated, but I totally agree that, of course, we need to develop these tools. We need to make some progress because of AI. And just to soften a little the fact that there is AI everywhere, not really, because sometimes we say there is artificial intelligence and it's not really artificial intelligence, it's just a sophisticated tool, but that's true that it's developing in the field of cancer. GDPR was conceived in the beginning to homogenize the rules in the European countries, but also to protect the rights of patients and of all the people. And it's a good thing in a way, because it's here to protect people, because there are really misuses. We know that there are a lot of hackers that want this data, and we don't want to see our data spread or just known by our employers. So it's really important to protect them. But it's true that for research, there are some obstacles, and maybe some ways could be found with the authorities, thanks to patients. Yes, but in a specific way, for specific ways.
Is there another question?
Yes, Dr. Efficace has shown an excellent overview on integration of quality of life in clinical studies. Which is the philosophy now, how to integrate quality of life and patient-reported outcomes in daily life? So that might also be a question to the patient representative, how to use quality of life, patient-reported outcomes in daily life in MDS patients?
Well, thanks, because you are opening the door to a very important topic that I didn't address. But yeah, this type of information ideally should be used also in clinical practice to monitor symptoms of the patient in real life and to focus discussion. I mean, to my knowledge, this experience in MDS is not, there is not that much in terms of publication. I would say basically very little or nothing. But we know that in other disease, this type of approach that is monitoring patients' quality of life and symptoms in real life, with this type of approach where the physician, for example, the patient complete the survey in the waiting area, and then results are presented in real time to the physician screen, can provide a number of benefits in terms of improving communication, because you can stay focused. For example, if you know that there is a peak in fatigue and there is nothing in dyspnea or whatever, you can stay focused in your discussion in talking about that specific symptom, which is important for the patient. So there are a number of evidence in other disease saying that this approach is working very well and has a number of benefits. Not to my knowledge in MDS, but I guess it's something that should definitely be on the agenda. Of course, there are a number of challenges to address in terms of logistic, administrative issues, and so on. But in terms of methodology, in terms of information technology, there is the answer is rather positive.
Thank you.
So, Dr. Zaiden, was there, were you able to measure compliance with the oral agents and patient symptoms? Was there any correlation between compliance and
Yeah,
symptoms?
not in this particular survey. I think, there are a lot of important things you want to ask about, but, I do quite a bit of survey, and you always want to balance how many questions you want to put in, because if you have too many questions, what ends up happening is that either people do not answer or they do not complete the survey, and then it becomes a problem to kind of make what you sense. But you're right. I mean, I think all of these are important questions, and hopefully we can look at them in subsequent surveys.
Especially with all these new oral therapeutics we're giving. Patients are just handed medication and then they come back to the clinic in between for count checks, but are they stopping on their own because they're not feeling well? And when they come into clinic, they say, I missed a couple of doses. And so there has to be this educational piece and monitoring about.
I completely agree. I think it's very, and this is we emphasize this to patients all the time, the fact that you are doing an oral pill does not make it any less of a chemo. So you clearly have to monitor the blood counts, and the patient has to be educated, compliant. I think the biggest advantage of these drugs, in my opinion, is the future potential for combinations. We are already doing that in AML, where you are taking 2 oral pills to treat acute leukemia, which is amazing. So I think this is the direction which MDS will go, is that it becomes a platform to build on other subsequent treatments.
And my other comment is just about the whole world of artificial intelligence in medicine. It is, how do we prevent, making sure that these data sets are not perpetuated with wrong information, the bias, and then you have an outcome that you might not be treating a patient correctly or diagnosing them correctly, and then you get the legal aspect of who's liable for that if wrong information is given out. Is the physician ultimately responsible because plugged in all this information and wanted guidance and care for that patient? So it's really something that has to be monitored and regulated very closely with expertise, people that know the disease.
Yeah, so thank you for this really important question, because it's true that we have talked a lot about that question of responsibility. And I think that's why in the European Union we talk a lot about human guarantee, because today the solution I think that is in the mind would be that there will be always a human, the physician, that will be there to control the results. This means that the physician will have to exerce its critical judgment and not just to rely on the tool and to say, okay, I have my results, because we have really to have in mind all the bias, all the risks, and so to really look at the results. So it's really, really important. Yes.
So it's time to go. Thank you very much to be with us at this session, and thank you for your participation.
Enjoy the rest of the meeting. Yeah. Thank you.
Thank you for staying.
Bye.
Thank you.